I really appreciate the group allowing me to spend some time talking about the Maternal Mortality Review Panel's work and report today. And first, I just want to take a moment to honor the individuals, families, and communities that are impacted by maternal mortality, and also to acknowledge the social structures and histories that contribute to these deaths. Just recognizing this is a difficult and emotional topic. It illuminates aspects of our work and our world that are deeply disturbing. And just recognizing that we know when people die during and after pregnancy, they leave a hole in the hearts of their families and communities that may not always heal and can't be described in words, let alone described in data or in a report. But we do this work, and I know you all are doing work to prevent deaths and improve care for all people, and to share what we all learn from each other so that we can create change on all the different types of interconnecting systems levels it's necessary. So today I'm going to give a bit of an overview and background of the Maternal Mortality Review Panel. I'm going to talk about some of the key messages, data, and findings from the report. Just want to make sure that these slides are advancing on the screen. Is that okay? Great, thank you. And then also recommendations from the report. And it's been not just a year, and about a year and a half in since the report came out. So talking about like where we're at with implementing recommendations from my perspective, also happy to hear anything from anyone else's perspective, and to connect it to your work, talk about applying recommendations to your work and your priorities. So let's give an overview and background first. So the big picture of maternal mortality, we often talk about maternal mortality as the tip of the iceberg. And generally when we say that, we're thinking about it in terms of also severe maternal morbidity and the fact that at least 60,000 people each year in the US experience severe complications related to pregnancy and childbirth. But it's more than that as well. It's also about people having negative experiences of care of all types that can impact their health, wellness, and their willingness to seek care in the future. And it just connects to everybody, wanting everybody to have a positive and safe experience in pregnancy and postpartum. I've also started thinking about this tip of the iceberg question in terms of the data in the report. So in the report, we give data on pregnancy-associated deaths, all the deaths that took place during pregnancy and postpartum, and then also pregnancy-related deaths that the panel identified as such. But in that category of some deaths that are not determined to be pregnancy related, there are some that we don't know. We mark them as unable to determine pregnancy relatedness, or maybe if we had the kind of information that we can't currently get from records, maybe we would know something different. But in reality, even in some of those deaths that are not pregnancy related, it's tough for the panel when they look at the case narrative and they see that the death might have been preventable, and they see opportunities for intervention at whether it's the provider care level or the social systems level. And they want to make sure that when we look at pregnancy associated deaths, that those matter too, the ones that are not pregnancy related, because there are opportunities to save lives in so many different places in this work. So the panel itself was established by the legislature in 2016, and then in 2019, the law was amended to make the panel permanent and to add some details to strengthen the maternal mortality review process. And the law guides our work. It directs the MMRP through DOH to conduct these comprehensive reviews of deaths of Washington state residents during pregnancy or up to 1 year after the end of pregnancy. The panel itself, as I said, is housed at the Department of Health. It currently has over 80 members. In the period of this report, it had a little over 70. And we have about 30 to 45 members at each meeting. A large panel allows us to make sure we have certain expertise areas represented. And we do have quite a breadth of expertise areas and backgrounds, so it's also always growing. We have an especial priority on growing expertise from American Indian and Alaska Native communities because of the striking disparities that those communities experience in this state specifically. And we give a report to the legislature every 3 years. I mentioned that wealth of experience. This is a word cloud of just some of the types of experience represented, everything from indigenous lactation counseling to maternal fetal medicine, substance use disorder, tribal health, lived experience, perinatal quality improvement. And we're also always identifying areas in which we could grow and need expertise. But I feel proud of what we have in Washington, and I love working with the panel. It's really just one of the best parts of my job. So how the cases are reviewed. So I want to emphasize that these cases are reviewed very respectfully. We honor, like as I did at the beginning of this presentation, we honor the lives lost. We encourage the panel to think of each person whose death we review as though they were a relative or other loved one. The panel reads an anonymized, de-identified case narrative summary. They don't know who the person was. They don't know where they received care. And they talk to determine whether the death was pregnancy related, and that could include exacerbation of an unrelated condition by the physiological effects of pregnancy. If it was pregnancy related, was it preventable? And in Washington, we ask not just was it preventable from a clinical perspective, but also was it preventable from an equity and or social determinants of health perspective? And not every state does that, which honestly is kind of shocking to me. We ask questions like whether racism, discrimination, and bias played a role. And then we identify for the pregnancy-related preventable deaths, we identify, well, what factors contributed to the death? And what recommendations would we make to address those factors? What were the opportunities for intervention? And so all of those recommendations that they brainstorm in that meeting, that ends up becoming the basis for the legislative report every 3 years. We pick among those and we figure out what is going to be the highest, strategic for systems change. And so this is kind of a look at our whole process here, beginning with identification of pregnancy-associated deaths. There's a pair of nurse abstractors who get all of the medical and other records and abstract them into those anonymized case narrative summaries. And then our third level is the panel review that I was just talking about. At the fourth level, every 3 years when we're preparing for the report, we come together to identify what are those systems level recommendations to prioritize. And then finally, we produce that report. And so the report itself, it's pretty easy to Google. You may already have a copy of it, but here's also a QR code if you want to scan it. It came out in February of last year. Again, it covers Washington residents who died during pregnancy or up to 1 year after the end of pregnancy. The data in all of our reports are cumulative. So this report goes through 2020. And so the data covers 2014 through 2020 deaths, but the recommendations are the ones that are newer. So those are, in this case, are 2017 through 2020 deaths that were pregnancy related and preventable. I just want to note about the years. So the legislature has us doing these reports every 3 years. This one, they actually got an unusual extension for to include 2020 deaths so that we could reflect at least a little bit of the pandemic era. But we are held by literally how the state law is written, the original 3-year schedule, which means the next one's coming out a little less than 3 years. So it'll be out in October 2025. This report has over 100 recommendations, and they're organized into 6 priority recommendation categories. I emphasize the over 100 recommendations part because later on in the presentation, I'm going to give you, a couple examples in each of the 6 categories of recommendations, but it's in no means a comprehensive list. So the report also includes an addendum from the American Indian Health Commission. And this is at the end of the document. And this includes recommendations from tribal and urban Indian health leaders and communities based on convenings that the American Indian Health Commission organized. And this was added to the report in response to deep disparities for these communities that were reflected in the 2019 report and again are reflected in this report. And the addendum discusses the report data and makes additional, 7 large priority recommendations that reflect inequities, social determinants of health, and strengths in American Indian and Alaska Native communities. So let's talk a little bit about the messages and data and findings in the report. So just first, stepping back, data considerations, maternal mortality is thankfully a rare event. And observations from maternal mortalities in Washington aren't necessarily generalizable outside our state. Small numbers do make rates unstable, so that it does make it difficult to discern true change on a year-to-year basis, and that's just that's how working with these numbers is. But we can still make meaningful recommendations and observations and interventions from the data that we have. So a couple of the questions people often ask, whether rates in Washington have increased. And so in this data period, 2014 through 2020, the rates have remained relatively stable. However, and this is a huge however, disparities persist. Washington's rate is lower than the national average. So I'm going to show you some more details about these and some other pieces of data. So I mentioned that rate being stable over time. So that's the top line you see here, the green line. That's all maternal deaths. And then the blue line and the orange line kind of add up to the green line. So the orange line is the portion of those deaths that are pregnancy related, and the blue line are those that are pregnancy associated, but not pregnancy related. And you'll notice that over time, it looks like a larger share of the deaths are pregnancy related. I don't think that actually means more of the deaths were pregnancy related. I think it reflects our kind of growing process as a panel and greater understanding of pregnancy relatedness. So I mentioned Washington has a lower rate than the national average. So our rate, and this is for pregnancy-related deaths specifically, is 15.9 pregnancy-related deaths per 100,000 live births, compared to, as close as we could similarly estimate it, a US rate of 18.6 pregnancy-related deaths per 100,000 live births. However, our rate includes deaths from substance use overdose and suicide, which is increasingly becoming incredibly important as part of maternal mortality. And the US rate doesn't include any deaths from accidental or incidental causes in this period of data. So that difference between Washington and the US might be even more striking if they were measured fully the same way. The US rates have been increasing since the 80s, and the US has a higher rate than comparatively wealthy nations. So looking at the numbers from 2014 through 2020, there were 224 total pregnancy-associated deaths. And that's, again, a death for any reason, any cause that happened to take place during pregnancy or up to 1 year after the end of pregnancy. And of those, the panel identified 97 pregnancy-related deaths between 2014 and 2020. And of those, 78 were preventable, and that's 80% of the pregnancy-related deaths were preventable. And I want to talk about that a second, because that number has really jumped out to people since we released the report. Like, that sounds huge. 80% of pregnancy-related deaths were preventable, and that's higher than the last report. I think it was around 60% in the last report. Again, I don't think it's that more of the deaths were preventable. I think it's that we understand preventability better. Adding in, it was just in, I think a couple of years before I started, that they started asking about, is it preventable from an equity and social determinants of health perspective, for example. And so this high percentage reflects that better understanding of preventability. And it also, I see it as an opportunity to take action, because it means we understand what's going on. We see what's behind maternal deaths. So I mentioned disparities persisting, and I'll show you the data on this in a moment. The most striking disparities, as you'll see, are for American Indian and Alaska Native communities, Native Hawaiian and other Pacific Islander communities, non-Hispanic Black communities, people covered by Medicaid, and people living in rural areas. And of these, the American Indian and Alaska Native communities experience the most striking disparity. And notably, the panel identified some form of discrimination, bias, interpersonal racism, or structural systemic racism in nearly half of the preventable pregnancy-related deaths from 2017 through 2020. So let's look at these data. And if you want to kind of spend more time with these data, I have the page numbers for them in the report. Let me describe a little bit of what you're looking at. So on the left, we have the all maternal deaths, the pregnancy-associated deaths. And on the right, we have the same figure for pregnancy-related deaths. The blue is the rate per 100,000, and the orange is the actual number. So for example, when you look in urban versus rural residents, there are more people living in urban areas than in rural areas. So you have, a higher number for urban, but you're going to have a higher rate for rural. So that's how you have to look at the disparity. But you'll see what I mean here about where the disparities stand out, and particularly for American Indian, Alaska Native communities. If I recall, in the pregnancy-associated deaths, the column on the left, I think it's 8.5 times higher than the rate for non-Hispanic white communities. And that's not even, the baseline we should be measuring by. We should be measuring by no preventable maternal deaths whatsoever. So again, we understand the role of racism, discrimination, and bias better due to changes in how the panel reviews cases and also how our epidemiologists review data on communities with smaller population numbers, which is incredibly important to do. We recognize that communities that are most burdened by perinatal health inequities have the expertise and cultural knowledge to lead solutions to reduce maternal mortality. And that's like behind the motivation of having the addendum from the American Indian Health Commission, for example, and some of the other work that we do in implementation. Similarly, some of the work we do in implementation reflects our awareness that Black, Indigenous, and other communities of people of color must be centered as leaders for the successful implementation of many of the recommendations in this report. So a couple of questions again that people tend to ask about the report. So, what were the leading causes of death? And I'll show you the data on some of these again in a moment. But behavioral health conditions are the leading cause, predominantly by suicide or overdose. And then the second leading causes are hemorrhage and infection. People say, well, okay, the report went into 2020, so do we understand the impact of COVID-19 on maternal mortality in Washington? And the answer is not really, because the numbers are so small. And this is a case where we just can't say something specifically about this is how COVID impacted maternal mortality in Washington based on these numbers. But we do see the impact of COVID in the report because we see the impacts of the pandemic era, and where that mostly shows up is in the recommendations, where you're going to see recommendations for things like strengthening telehealth infrastructure and addressing provider shortages. And, both of those things mattered before the pandemic, but the pandemic really brought them into focus and, extended the need for them. So that's where we see the COVID era reflected. And of course, there's lots of good national and global data on that question as well. Sometimes people ask, well, why do you look at through 1 year postpartum? And I think this group understands the answer to that question. But you'll see in our data in a moment that many deaths took place in the later postpartum period, particularly with behavioral health conditions. So let's look at some of the numbers here. So this is the manner of death and 3 leading causes of pregnancy-related deaths in 2014 through 2020. So you'll see that behavioral health was the highest category. And of those, suicide was the highest number, followed by overdose deaths. And then the second highest is hemorrhage deaths, followed by deaths by infection. I was talking about the timing of the deaths. And so this is sort of the 4 categories of timing. So pregnancy, the same day as delivery or fetal demise, pregnancy, up to 42 days postpartum, and then 43 to 1 year, 43 days to 1 year postpartum. And you'll see that relative to about how long those periods are, it's pretty evenly spaced. But the fact that we see, over a third of these deaths are in that later postpartum period really reflects the importance of including that in our discussions of maternal mortality. So that's a good thing to mention if people ask, why would somebody do that? I want to take a deep dive into behavioral health data a moment in the report, because I know that's on a lot of our minds. So looking at demographics for a moment, for pregnancy-associated deaths, this is the larger umbrella, from unintentional substance overdose. So these primarily occurred to younger people who are 30 years old and younger, non-Hispanic white communities, people who are insured through Medicaid, and people in urban areas. And American Indian and Alaska Native communities did make up a disproportionate number of these deaths. So I mentioned how that timing was particularly striking for unintentional substance overdose deaths. And I apologize that this graphic is designed a little bit differently than the other one showing the 4 time periods. But you can see here in the 4th circle, on the one on the right, that nearly 2/3 of deaths from unintentional substance overdose, pregnancy-associated deaths, were in that later postpartum period. So that really stands out to us. So demographics of pregnancy-associated deaths from suicide, again, these primarily occurred to younger people, 30 years. Oh, I'm sorry. I misread that several times. These primarily occurred to people who were 30 years old and older, and then living mainly in urban areas, insured through Medicaid, And this was primarily what we were looking at was deaths via intentional substance overdose, hanging, and firearm discharge. And so looking at the timing of suicide deaths, again, we're seeing a really striking number. Over half of them are in that later postpartum period. It's also standing out that a quarter of them are during pregnancy itself. So yeah, I think these are important to pay attention to. So let's talk about the recommendations in the report. So I mentioned that the panel identifies contributing factors that lead up to each death, the events or issues that, if these were changed or averted, might have prevented the death from occurring. And we categorize these, the CDC asks us to do this based on kind of 5 different levels, from the patient or family, provider, facility, systems of care, to community level. Very few are at the patient and family level. We're generally looking at systems and structural issues, but also looking at, provider and facility issues. And I mention this because when the panel identified contributing factors, most of the ones that they identified were at the systems of care and provider level. So thinking about that as we move forward, like, you'll see that reflected in the recommendations. There's a lot of recommendations for providers, but also for facilities that can enable changes for providers, and also a lot of systems level recommendations. You saw very few patient and family recommendations. So again, if you didn't get the report before, here's the QR code again. The recommendations in the report fall under pages 51 to 75 in those 6 broad priority recommendations. And each of the 6 categories starts with a page or so of background information to talk about why this is a priority. So citing some other sources, talking about other things it's in alignment with, and things like that, and recognizing places in the report's data itself that have led to this being a recommendation category. Within each of the 6, we have recommendations for 4 general audiences. So some are for the legislature, some are for providers and facilities, some are for all types of agencies and organizations and institutions, and then some are for the Department of Health itself. So the first of the 6 priority recommendation categories is about addressing racism, discrimination, bias, and stigma in perinatal care. And it's intentionally first. And a couple of examples of the many recommendations under this are things like expanding and diversifying the perinatal workforce to reflect the cultures and languages of communities, prioritizing access to perinatal care in communities that are experiencing inequities and disparities, and then funding community-driven initiatives to address these issues like structural racism, social drivers of health, and promising solutions. The second priority recommendation is about mental health and substance use disorder. So this is increasing access to mental health and substance use disorder prevention, screening, and treatment for pregnant and parenting people. And I believe this one actually has the highest number of recommendations under it. Couple examples of them are things like increasing the number of residential treatment facilities that allow parents and children to be together, providing coverage for additional postpartum hospital days for people who need medication for opioid use disorder or stabilization and support, and improving and reimbursing for screening of mental health, substance use disorder, and suicide. So the third priority recommendation is about healthcare access. So expanding equitable and high quality healthcare by improving care integration, expanding telehealth services, and increasing reimbursement. Couple examples of the recommendations under this are things like expanding home visiting services for pregnant and postpartum families, supporting legislation to increase access to doulas and midwives through 1 year postpartum, and increasing awareness about Medicaid eligibility, Medicaid terms and types of health services that are already available, and also provider options during pregnancy and postpartum. So if that one was about healthcare quality and access, healthcare access, the fourth one is about healthcare quality. So this is to strengthen the quality and availability of perinatal clinical and emergency care that's comprehensive, that's coordinated, culturally appropriate, and adequately staffed. So a couple examples of recommendations are things like ensuring patients are receiving individualized ongoing postpartum care for a full year after the end of pregnancy, strengthening care coordination through multidisciplinary care teams, and then providing training and drills for providers, including emergency physicians, on how to coordinate with obstetricians if you're responding to an obstetric emergency. The fifth priority recommendation is about basic needs. So meeting basic needs of pregnant and parenting people by prioritizing access to housing, nutrition, income, transportation, childcare, care navigation, and all types of culturally relevant support services. So things like increasing access for pregnant and postpartum people to safe, affordable, and stable housing, um, expanding child welfare supports that focus on stabilization and wraparound services for pregnant people and early parents, strengthening care coordination systems that connect pregnant and postpartum patients to appropriate and culturally relevant social supports, navigators, and other service options. And then finally, our last priority recommendation area is around violence prevention. So this is preventing violence in the perinatal period through survivor-centered and culturally appropriate coordinated services. A lot of these are about funding. So increasing funding for resources for supporting survivors, safe housing for pregnant and postpartum people and families, free legal services for families, public health approaches to upstream violence prevention and things like that. There's also a lot of screening. There's a lot of screening recommendations throughout the report, but there's a recommendation for universal screening for interpersonal violence and personal safety, and then also ensuring training on the increased risk of intimate partner violence during the perinatal and postpartum period. So let's talk about implementation now that we're actually about a year and a half since the report came out. So I'm sure many of you are familiar with the Washington State Perinatal Collaborative. Can I get a either show of virtual hands or in the chat how many folks are involved with that? Seeing some hands and some recognition for that. Awesome. And if you're just finding out about it, there's a QR code, or it's also easy to Google. They actually just started a monthly newsletter that's pretty fabulous, and so I highly recommend signing up for that. And their mission is to end preventable morbidity, mortality, and disparities in pregnancy, postpartum, and infant care through quality improvement initiatives and fostering a network of statewide perinatal leaders. And among other things, I think of them as kind of the implementation hub of the maternal mortality review panel, in that they're a place for a lot of different types of experts and advocates to come together and say, okay, these are the recommendations. How can we include these in our work strategically for systems change? That doesn't mean they do all of the implementation, nor does DOH. Like you saw how the recommendations are for all different types of audiences, including the legislature. But, I've had somebody from a group of doulas come up to me and say, yeah, we read the report and this is a change we made to our practice based on a recommendation in the report. That's implementing the report. Somebody from a community organization who cites the report in a grant that they're applying for, that's implementation of the report. And so I see the implementation process as both centralized and decentralized. Everybody owns implementation, and there are also coordinated efforts going on. So the Perinatal Collaborative has 4 initiative areas, including clinical quality improvement, community and patient engagement, infant care, and systems change work. So some of the other kind of structural things that are going on in implementing recommendations that DOH and other partners are involved in. So one of them, this actually came out of the previous report in 2019, the Center of Excellence for Perinatal Substance Use, and its relevance continues to be ongoing. And this is a hospital certification program to improve care for birthing people and infants impacted by substance use, and hospitals have to meet 8 criteria to become certified. There's also birth doula certification that started this past fall. Birth doulas can voluntarily apply for certification from DOH, and fees are waived until next summer. The Blue Band Initiative, this is for patients at risk of developing preeclampsia wearing a blue wristband. The Birth Equity Project, this really puts in practice some of the recommendations about centering communities in creating change around racism and equity issues. So this is some strategic investments in community-based birth worker organizations to reduce racism faced by birth workers and families. And these are current grantees of that project. The Smooth Transitions Project enhances the safety of transferring patients from home or birth center to a hospital when that's needed. Team Birth is a framework for shared decision-making and amplifying the birthing person's voice. There's a lot of initiatives going on around rural care access, which we know is a big issue in Washington right now. So they're convening some work groups of rural OB providers and building a cross-organization collaborative. They're building a maternal health task force that's prioritizing 5 key areas, one of which is rural health. And they're doing some data mapping and analysis work focused on rural care access. So finally, I want to think about connecting recommendations to your priorities. Thinking, so which from the report are most relevant in your region, in your field, in your community, whether your group's working on implementing one or more recommendations or hoping to start soon, and with whom do you want to collaborate? What barriers you might run into, what supports and strengths are there? Are there other efforts that you're aware of to implement recommendations at any level, even if it's just in like one medical practice? And yeah, just how can the report's findings and recommendations support your work and priorities? So these are questions I want to leave you with, and I want to share my contact information if you'd like to reach out in the future. And I'm happy to take any questions. And if there are any that I don't know the answer to, I can also help connect you with our epidemiologist or anybody else as well.
Well, I can't thank you enough. This is really powerful. And in fact, this is so powerful that when we first heard it, we brought it back to our group and said, the AAP says to do perinatal mood and anxiety disorder screening through 6 months. This data speaks otherwise. And so we've just launched at our practice doing this through 12 months. And the other thing I want to tell you, Debs, is that between this committee, the Washington chapter in general, we brought our concerns to the state about why do we only, there's payment for screening one caregiver, and that was taken by the healthcare authority to CMS, and Washington State right now exclusively has been granted permission to screen twice, two people 5 times in the first year.
That's
So
awesome.
I want every other state to know it so they can get it, because it was an ask.
Yeah,
But those are 2 direct things from the report,
that's
the
amazing.
implementation things. So this work has real meaning.
Thank you. And I also want to ask, like, I can try taking some notes as well, but if any of you have examples like that or anything else that you want to email me, I know my colleague who's kind of on the implementation end of things loves hearing about this stuff too. So that's wonderful. Thank you for sharing that.
Debs, this is Kathy Park. Thank you so much. That was really just so interesting and informative. And I was wondering, how can you speak to? You mentioned one of like the big groupings of findings was about like racism and discrimination and bias happening, and like what, like the how did people who are doing this work like count that? Like what
Mhm.
exactly were they like looking for, and like how did they decide that those were the factors that would indicate these?
Yeah, I mean, thank you for that question. I think it's with the work we do, it's always doing the best we can with the information that we have, and the information that we have is often limited. Um, in terms of structural racism, we err on the side particularly of people of color, particularly Black and Indigenous people of color, having experienced structural racism and adding to lifelong stressors that we all know the ways that they can impact health. So there's some pieces of that, but there are also clues that you can sometimes see in medical records, the way a provider is referring to their patient. Sometimes it's about somebody not having an interpreter that they're legally entitled to. Sometimes, you're seeing somebody not come back for care after, experiencing something that we're sort of seeing in the language of a medical record. Maybe there was something going on here. So those are some of the ways that it can look. But we also recognize that it's imperfect. But this is why we also emphasize we're looking at both structural and interpersonal racism and discrimination and bias. We're also looking at like bias in terms of stigma. So, I mentioned there's a lot of behavioral health deaths, and we all know there's a lot of issues around stigma in providers around pregnancy and postpartum and substance use. And so sometimes you'll be able to see stigma and bias about that reflected in the medical records or reflected in somebody, wanting to leave care early. And so that also is something that's counted in those numbers.
I have a question. I practiced in Washington for a few years, and then my husband and I moved to Texas, and I worked there for a similar program to the PAL program in Washington, for the Child Psychiatry Consultation Service. And before I left and moved back to Washington, we had been rolling out a perinatal consult line, which I know Washington has one as well. In Texas, the pediatric and the perinatal lines were actually integrated into the same service. And I know it's a little bit different here in Washington, but I know it can be kind of hard to track patient outcomes as a result of consultations with those phone consult services. Is that something that Washington is trying to do? I don't know if you know the answer to that question, or is there any way? I don't even know if there would be a way to do that, because it is just a consult service. They're not really tracking patient outcomes per se. They're more looking at the providers. So I don't know exactly what my question is, but just kind of had that rolling around in my mind.
Yeah, is there any tracking of kind of following up those conversations?
And how
I
that
don't.
outcomes.
Yeah, I don't know the answer to that. I have a colleague who I suspect might either know or might know who to ask if you send me an email about that. Yeah, I think
And I was just
Batsheva
thinking
Stein
that
might.
in the context of what you were talking about earlier with finding alternate ways to provide care, especially in rural areas where we just don't have enough psychiatric providers or primary care providers or OB providers, and how can we rethink how we're providing care so that we can maybe do virtual options or phone things to improve access to care for our patients. So.
I've been hearing a lot of that. So some folks at the University of Washington have been leading these MMRP across Washington convening sessions in different places around the state. They did some in the months after the report, and then they've just picked it up again recently. And yeah, people in rural areas are talking a lot about that issue and how it's getting harder and harder and all of the root causes of it.
Just want to call out a sentence that you said in there, and that something I think a lot about, really, Shayla, thanks to you, when you're talking about one of the addressing racism, community-driven and funding community-driven initiatives. And the more that like our group has been involved in some of the grants, you just realize how infrequent it is that the communities themselves are given the money to do this, and they have solutions.
Yeah. Yep. Yeah,
And
I'm glad there's growing awareness of that.
how can we use like wield our power and privilege and positionality to change that?
I think continuing to speak up about that, I think if, when groups have funding and value that, specifically putting funding toward that and publicizing it, making this more and more of the norm. Also reduce, talking to the types of organizations and groups that would be funded about like what are their needs financially, what are their needs in terms of creating a process that doesn't have too many barriers for application and for reporting. I think we've all heard and or been involved in stories of organizations just having to flip over backwards for small amounts of money, and limiting barriers, also encouraging communication and storytelling about the work of community organizations, sharing voice, sharing power. Yeah, those are some of the pieces I'd focus on. But I
Thank
also
you.
welcome anybody else's thoughts on that too.
Hi, Imka Lavender. I have one question for you. I was looking at the PowerPoint that Marianne and Rachel had shared from a conference they went in California, where they actually drilled down that talked about perinatal mood disorder, now 1 in 5. The last thing that came out from AAP was 1 in 7. Do we have Washington numbers if we can say 1 in 5, or is that I was kind of listening to see if we have Washington numbers versus that the 1 in 5 is more California based. I was reading their presentation.
Mm-hmm. Yeah, I'm not as familiar with general data beyond maternal mortality data, but I could probably find somebody who would know if we have that. Again, if you want to send me an email. One thing I will say is that I wouldn't be surprised if those numbers are going up, considering all of the systems and structural stressors that contribute to that. And that this isn't, those things aren't just popping up from people individually. There's a lot of factors that work there, and we know that the world is getting harder.
Yeah, we've just started screening the 9 to 12, so we'll have a full year of data to see the differences between, that we used to stop at 6 months, and real interested. We just started that, I think we're 2 months in now, so 2 months into the expanded 9 to 12. So I'm interested to see what we'll learn, and it just seems with what we're already seeing, and that it would just so make sense for there to be a 4-month, a 6-month for mom versus the pediatricians for the babes. And again, the babes need it too, but boy, wouldn't that be if we paired, what babies get that mamas get. So, or caregivers, I should say, that might be a more appropriate word. So thank you for your presentation. That was very enlightening.
Yeah, thank you for your thoughts on this. I kind of have a question for you all, which is there something that the maternal mortality review panel can be learning from the field of pediatrics that we may not currently be learning that could benefit this work?
Rachel, I don't know if you have little ones right with you right now, but I think some of the work that we're doing now with having community health workers address from the beginning, introduce to families, I think that could be helpful, because what we're finding is that families are sharing with the community health workers, even with like a really strong continuity of care model, they're sharing other concerns and worries with the CHWs that they might not share with their primary care. But Rachel, you expand on that?
Yeah, to expand on that, we're introducing the community health workers at the 1 month and 2 month visit and weight checkups. And even if it's just a preliminary introductory conversation that's very brief, we are finding that families are going back and noticing that this is someone that they can talk to. So even if they're not disclosing anything right off the bat in that first introduction, they're following back up with the community health worker and sharing things that they didn't during that appointment. So more touch points, the better. And I just want community health workers to be embedded more across the state.
Thank you.
We'd love to share it. Like if there's a forum or a way that we could share any of that. I think all of us on this have interest and a lot of experience. And I looked quickly to see if I could see the word pediatrician on the panel.
That's an area that we're missing, actually. And that's a conversation that, it's a conversation we've had. Is this something that we should add to the panel? And I was kind of advocating for, yes, this is. But if your group feels like, that's something that's missing, like that's something that I can take back and say, hey, as we revisit who's on the panel, this is something we might want to do to expand. And, if you want to send me examples of perspectives pediatricians might be able to contribute in a panel review that might otherwise be missing, that could go a long way.
Okay, Emily and Caroline, maybe we will put our heads together and then put it out to the wider group to add into it.
Okay.
Especially we take care of teen parent.
Yeah.
I saw one today. And so I don't remember seeing it by age. I'm sure it's in there, but I'm sure they're reflected. I mean, it's the under 30s.
Yeah. No, that's a great point. Thank you.
This is Rita, and just to echo, I guess, a couple things. Like I think our Anameta can correct me if I'm wrong. We are also doing community health worker checks with our newborns in the Longview office, and then we have care coordination and a community health worker who works on lots of different things in our Vancouver office, who we frequently tag to talk to families and help network with various resources, including behavioral health and counseling for our families that are dealing with especially postpartum depression, anxiety. The other thing, I did the same thing. I was looking at all the words, like, where's the pediatrician? Is there a pediatrician? Yeah. I think there's so many gaps. And I've seen this on the work with the child fatality board, where we just drop the ball. People disappear. And so it seems like an obvious gap to me, or something that would be connected, is kids who aren't getting primary care, babies who aren't going to those visits. What's going on with the family, and how can we connect with them? And I think our practice does its best to sort of call back, find out what's going on, but you can't really control who's going to pick up the phone or not. And then there comes a point where, yes, we can't schedule and reschedule, but we do the best we can. We actually just had a meeting with Nurse Family Partnership today from Clark County, and we were talking about that very issue and how they have helped certain families advocate to make it to those appointments and help combat the barriers, whether they're it's housing or transportation. And so I do think having a pediatrician on the review would be helpful, and we should take so much better care of mothers, that's for sure. I hear all the time in Clark County that there is such a lack of prenatal care, period. In fact, one of my patients who used to be my patient, who now is a mommy, and she works for CMAR, and she has said that she doesn't want to have another baby right now because there just isn't great access to OB care. So
yeah, the things that actually impact choices about parenthood, when there are choices made, sometimes depressing.
The commonality that we're hearing, whether it's at the summits, Kailani, or just all these different meetings that, like, people are really interested in this topic, the themes I hear over and over again, how scared women are. And that's just a terrible sadness about this. And that combined with, I don't think I'm going to be heard.
So Amrita brought up the CHWs, and in Longview, we have started having them come in. If it's a weekday, they come in at the 2-day visit, the 2-week visit, the 2-month visit, and give information at each of those visits. We also have, it's kind of tied into connecting them with our lactation consultant that's in-house. One of the challenges that we've found is trying to access those families that don't establish care in the first week of life. So because I think the more support we can give to these families, whether it's through the pediatrician's office or through Nurse Family Partnerships or through any organization that's out there, depends on knowing who these families are. And I mimic one of my conversations that I've had with Phyllis for the last 20 years is, I think we do a reasonably good job within our clinic of taking care of the people who show up at our clinic, but what about all the people who don't show up at our clinic? And how can we figure out who they are and how we can access them? We have been struggling for the past 6 months to say, can we at least get somewhere a list of babies born in our county? And we can't seem to figure that out. We currently have no docs in the hospital here in Longview. So we lost access. How many of these babies are ours? How many of these babies belong to somebody else? And making sure that they connected. But now we don't even have that. And we can't figure out how to get access to that, to make sure these kids see a doc in the first 2 months of life.
Wow.
So I don't know how to fix that. But I don't think that's unusual for rural hospitals.
Does that resonate with other people as well?
Yeah. And I thought of it, just another really important reason a pediatrician or two should be on the review board. Anything that improves the communication between the obstetrical, the family practice, and the pediatric space is a win. And Kailani is co-leading First Year Families, which is really, it's a stakeholder group and a steering committee to really address that. And this would be one more touch point. And it would get to, like, Imka, your vision of, like, what if there were these, that we were all communicating really tightly and the parents were being seen not at like 6 weeks and then never again, that where we could actually be in conversation about it and centering families, like to have like Shayla's voice on that, the family's voice saying, this is what's missing. Well, it's true, Shayla. I'd love for you to share.
I'll make it snappy. I know we're past time. This presentation was very, very, very difficult, being one of those complicated birth people that I know that the only reason I'm here is by the grace of God, because it definitely wasn't the care that I received. So this was hard to listen to, but I'm so grateful for all the work that you're doing, Debs, and all of your colleagues, and the fact that you all are on this call, genuinely from the bottom of your heart, working towards the goal of better partnering with families and genuinely saving lives. And so everything that you all are saying about the communication piece, to me, is so valued. I didn't have a pediatrician lined up when I had my baby, my first baby with complications. And my OB happened to be off that night when I was essentially kicked out of the hospital because I wanted to go see my baby before they had to do ECMO. So I left 20 hours after a C-section with staples. I just wish there would have been more people to communicate and speak to what we were going through, because I know I could have died, and so I'm just thinking about all those women who didn't make it, and so I'm just very grateful for all of you. Thank you.
Thank you for saying that. Yeah. And that's, when I was talking about the tip of the iceberg piece, knowing that there's so many people who have harrowing stories and barely made it, and that this affects them, that we recognize and honor that too, as we recognize and honor the people who lost their lives. Thank you for sharing that. Well, is there anything else? I don't want to keep people too far over.
I will send out Deb's information in a follow-up email to all of you. But thank you all so much for, spending your evening with us. It's always good for us to be in a call together. And if you have any questions, let us know. But the next thing for our early childhood committee is a retreat in October. And then our next Zoom meeting is in November. So we'll see you all soon. And thank you, Debs, again for joining us this evening and sharing the findings and recommendations to our group.
Yeah, thank you for the opportunity. Thank you all for coming. Okay.
Thank you very much. That was great. Yeah, thank you for lining